So, hello everyone. Myself, Dr. Sandeep Dahilekar, Professor from Rog Nidan Department. Today we have our PIA Saturday Pedagogy sessions, a 52 Saturday PIA Pedagogy session. Today we have our resource person, Dr. Swapnil Raskar sir. Swapnil Raskar sir has completed his UG from Tilak Ayurved Mahavidyalay, Rastapet, Pune, from Maharashtra. He has completed his PG and his PG from ITRA Gujarat Ayurved University Jamnagar, Gujarat in Komar Bhritya, that is Baldok. He has also completed his PhD too in neonatology from ITRA Jamnagar, Gujarat with the merit rank. He is practicing pediatric and uh, neonatology for more than 10 years now, with the vast experience of subject in the theoretical and clinical pediatric and neonatology. Presently, he is working as associate professor at Parul Institute of Ayurveda, Parul University, Vadodara, Gujarat, and is always in search of newer teaching method and techniques for the improved understanding to subject to the student. He has completed more than 5 research projects and has guided many PG researchers in pediatrics and neonatology. Recently, he has developed a new Ayurvedic drug formulations for pediatric COVID-19 management. He has received honor from Dabur India Limited for his work in Ayurveda for his Ayurveda clinical fields. He is practicing Ayurveda pediatric in Vadodara, his own OPD also in the evening. Since last 7 years, and many children with the lethal disease has benefited with his service and in the field of expertise. So this is all about Dr. Swapnil C. Raskar sir. I requested to him, dear sir, the session is your.
Okay. Yes. Thank you, sir.
Yes sir, please share your PPT sir.
Yes, sir.
Yes sir, it is visible.
Okay. Okay. Thank you, sir.
So please go. Yes sir, slide show is also visible.
Uh, okay. Good afternoon, everyone. Uh, Today in pedagogy session, we are going to see the topic childhood COPD, that is chronic obstructive pulmonary diseases. Today, I choose these topics because there are many facts and myths regarding this topic. That is there any such entity like pediatric or childhood COPD is there or not? So let's start. What is COPD? Actually, this long session of pedagogy session, many times, many lectures, many session has been taken in which what is COPD is already cleared. But still, I'd like to clear some basic initial points. What is COPD? Very first of all, as the disease name itself suggests, it's a chronic. So it takes year to take to form the pathology. It's not like that of any acute or insidious pathology. The name itself suggests its chronicity. Coughing, the chronicity in the form of coughing. Coughing varies from different ranges like barking cough to hacking cough and productive cough to dry cough, nocturnal cough. A range of coughing and symptoms shades are there in COPD. Dyspnea and weakness, especially exertional dyspnea and weakness. It's very initial cardinal hallmark there in the COPD. Many times in the adult population, we taking these symptoms either in a pulmonary form or in a cardiologic pathology form, cardiac pathology form. But in case of pediatric population, there is a less chances of pediatric cardiac pathology. One second, some technical problem.
So your slide is not visible.
Yes.
Yeah, it is now.
Yeah, yes, yes. So, in case of pediatric population, there is a very least chance of cardiac pathology, and many times these symptoms indicates more or towards any metabolic error or any metabolic or pathologies and pulmonary pathology. Wheezing, wheezing is another important hallmark in pediatric population. It means wheezing is there in almost each and every case of COPD. Here we have to take very careful while taking wheezing as a sign of COPD or other any pulmonary pathologies in pediatric age. Yes, breathlessness. The intensity and proportion of breathlessness is far more as compared to the adult population, and the consequences and outcomes of this breathlessness are found more in pediatric population as compared to adult population. And respiratory failure is also take in a very drastic or dramatic way. So we have to right from simple coughing to respiratory failure, the ranges of the symptoms are there in a childhood COPD especially. As everyone knows, that chronic obstructive pulmonary disease especially has been categorized into two broad infra, that is emphysema and bronchitis. In both the cases, there is a collapsed airways has been found, and such a collapsed airways, air trapping is there, and because of inflammation, the air volume exchange is also very less, and that's why there is the symptoms of air hunger, and day by day the symptoms gets worsen or lethal, and at the end stage there is a respiratory failure. In case of bronchitis, there is a narrowing of airways as the smooth muscles around the bronchus gets severe bronchospasm or gets tightened, and that again narrowing the airway passage. And over a period of time, this persistent bronchospasm may persist, and there is an inflammation inside the bronchuses, and mucus plugs has started being secreted inside, and there is an obstruction to pulmonary airway flow. And in a year way, in a years to go, there is chronic obstructive pulmonary disease pathology. Same way happen in the emphysema. There is an infection and insult to the pulmonary parenchyma along with the epithelial cells of the alveoli, and that there is a permanent damage to the alveoli, and in that way the physiological airspace where the actual gas exchange takes place gets compromised over a period and day by day, and ultimately there is a collapsed alveoli, and which gives rise to against collapsed airways, and there is a COPD takes place. Now, exactly what is childhood COPD? Contrary to common belief, COPD can ensue or takes place in pediatric population also. The only thing is that one has to be very specific regarding the age bar and the differential diagnosis of the disease. Here, why I'm talking about the age bar? Yes, it is very important that by and large, as a thumb rule, there is no cases of COPD, especially less than 8 years. In such a cases, because as we have already earlier we have discussed that it's a chronic disease and takes a year to form, so it is very clear that in very initial days that pathology is not ensues, and generally by and large there is a no reported case of COPD, especially below the 8 years of age. After the 8 years of age, if there is a permanent pulmonary insult or there is a pathology is going on as a consequences of different diseases, then definitely there is a chances of getting COPD after the 8 years of age. Specifically, if we want to go in very particular sense, COPD can occur after 12 to 14 years of age, and yes, there is a definite possibility of getting COPD by that age time. And some population nowadays researches has been reported that especially in adolescent medicine, it has been noted that in a pre-adolescent and adolescent proper age, the many, especially female populations, get affected with the COPD, and the starting of the pathology is takes place around 8 or 10 years of age. So it means it is very clear that COPD can ensue from childhood age. The only thing is that age bar one has to be always considered, and some differential diagnostic points and different diagnostic features one always has to take into care. The symptoms of COPD matches, especially I'm talking about now in the age bar, we talk about 8 years or more than 8 years cases. There are certain diseases which we have also taken into consideration before labeling the child as the COPD. Pneumonia. In certain pediatric population, there is a recurrent history of pneumonia, repeated history of pneumonia, and repeated insults to the alveoli, especially parenchymal cells of the lung, damages the alveoli, and over a period of time, some respiratory area gets collapsed, and there is a compromise of respiratory airways, and COPD ensues. Asthma. Many a times, the triggering factors of asthma continuously insult the
Swapnil
pulmonary.
sir,
Yes, sir.
try to speak loudly. Take your laptop near to your mouth and it will be loud.
Yes, yes. Now, sir.
Yeah, it is clear. Don't go away from that.
Okay, okay, sir. Now it is clear, sir.
Yeah, it is now.
Yes, yes. Especially talking about the asthma. Yes, asthma is also not labeled in very early childhood age. Especially the age bar for asthma is also considered as 3 to 5 years of age. Generally, by and large, as a thumb and clinical rule, you are not going to diagnose asthma in early periods of life. But yet, definitely, if the severity and exacerbation of asthma is going on in continuous fashion and triggering factors are have not been avoided, then it ensures the pulmonary insult and inflammatory changes, or one can say permanent inflammatory changes or long-standing chronic inflammatory changes inside the bronchuses and airways, and that also can lead to a COPD. uh, the cohort studies, different cohort studies, which has been conducted in childhood ages, especially 5 to 12 years of age children's, has been noted that around 8 to 10% of asthma having tendency to land up into adolescent COPDs. So that is also a clear message from such a research and cohort studies that one should not consider asthma as so lightly, as consequences can be later phases into COPD. Bronchiolitis. Different features of bronchiolitis, especially in the toddler age group, having mimics or having very similarities clinical features as that of COPD. But as we have already considered, there is COPD takes a year and takes a long time, and it's a chronic pathology. And generally, by and large, bronchiolitis takes place below 3 years of ages, and there is a recurrent episodes. And later on, as it's a viral pathology, the immune system of baby takes over, and the episodes of bronchiolitis resolves over a period of year. Bronchitis. Yes, definitely, allergic bronchitis and chronic bronchitis have a tendency to produce a permanent damage or insult to the airways, and that also, as we already explained in asthma, the same way pathology, especially in allergic bronchitis and chronic bronchitis cases, happens, and there that also consequence into the COPD in child in latter phase of life. Bronchiectasis, though bronchiectasis is a totally different terminology in clinical sense, that is a permanent dilatation of bronchiole, we have bronchus or bronchiole we are considering. But still, if there is a involvement of more airways, such a involvement of different airways, permanent dilatations also compromises the airways, and in later phases of life can be a seed for the COPD in the child. HRAD, hyperreactive airway diseases. The term itself suggests hyperreactive airway disease means there is a hyperreaction by the airways. There is a mucus secretion in response to the any triggering factor as an inflammation, and there is obstruction or compromise of the airway, and there is a high excuse me, airway diseases. And such a hyperreactive airway diseases can lead to the COPD in further life. So, what are the differentiating features that one has to be considered? Specifically, asthma has to be ruled out in very proper way in case of pediatric population. That is, yes, there is a definitely wheezing, breathlessness, and triggering factors are there. And in such cases, though such features are also common in COPD, but one has to take help of ACT, asthma control test, and asthma control questionnaires. With these questionnaires, one can identify the triggering factors and how there is episodes of asthma in a week or that. The main differentiating feature is that, especially I'm talking about more than 12 years old babies, the main differentiating feature is that asthma and COPD, there is, in case of asthma, there is a transient relaxation phases we can found, and specific triggering factors definitely we can identify to differentiate from COPD. Valry and COPD. Yes, again, we have just discussed about the bronchiolitis. So latter phases of bronchiolitis gives rise to Valry. That is, these associated lower respiratory tract infections. Specifically, these are the viral infection by respiratory syncytial virus and adenoviruses family, which gives repeated episodes of breathlessness and wheezing, coughing, especially nocturnal coughing, postural coughing. The same thing mimics with the COPD findings, but again, age bar and number of episodes varies. Yes, in COPD, the episodic pattern is definitely not there. Uh, but in case of Wallery, episodic pattern, we definitely found. That's why we consider it as a Wallery 1, 2, 3. And after that, we diagnose the case as hyperreactive airway disease. And in later on phases, we diagnose it with the asthma. And if such a thing continues with the proper investigation and spirometry after the age of 8 or 8 in between the 8 to 12 years, we can rule out or we have to cross check that if that asthma or Walry has not been lined up into COPD in childhood age. Pneumonia can lead to COPD in younger child. Key point to be remembered. This is a very important key point that every clinician has to be remembered that pneumonia can lead to COPD in younger child. Especially atypical pneumonias and viral pneumonias by syncytial viruses family group insulting the pulmonary parenchyma and alveoli. And after the resolution of consolidation, there is a chances of collapsed airways and collapsed alveoli. Over a period of time, with the immune system and regrowing capacity of child can regrow the things, but in 1 to 5% of cases, such a regeneration or you can say rehabilitation not takes place, and such cases land up into COPD in their later childhood, especially after the 12 years of age. Why this happen? Because we have to wait a while as there is a growing phase of child and the total adult pulmonary capacity and pulmonary efficiency has not been developed. So we should not be in a hurry to diagnose the COPD or to rule out the COPD. But yes, definitely recurrent infections, especially pneumonitis, can lead to COPD in younger child, as we explained, and it's a definitely key point to remember for every clinician. Now, what are the that clinical entities which lead to COPD? As we consider that's pneumonia, specifically atypical pneumonia by respiratory syncytial virus families. Repeated infections can lead into COPD. Chronic bronchitis cases are also etiological factor or consequating factor for the COPD. Chest trauma, yes, chest trauma is also one of the cause of COPD in children, and as already explained in previous slides about the bronchiectasis. Why children less prone to COPD? Physiology of respiratory tract. As we already explained that a growing phase of child in which the total absolute capacity adult capacity of respiratory system is not yet developed, and yes, there is a certain chance of to regrow, and anatomical growth as well as physiological variation is definitely possible, and that's why we have to give some time. We can't directly diagnose a COPD. Generally, as a clinical thumb rule, we can't diagnose the COPD before 8 years of age. The basic reason behind that, the physiology of respiratory tract. Yes, definitely there is a differences in force, functional residual volume and functional residual capacity of the baby. Actually, it is a very vague part. We are not going to that much details that why this FRV and FRC is not on cause the COPD in children. But just a point to be remembered. That's why I added in this slide. Now, what are the managements? Managements are mostly focused on the symptomatic relief and prevention of the pathology, especially prevention of the inflammatory changes and formation of Lucas plugs inside the airways is the basic thinking or basic cornerstone of the therapy, what we are considering. Yes, bronchodilators. There is a definite role of bronchodilators as there is a bronchospasm or due to inflammation. If there is a constriction of airways, definitely we have to improve the channels, volume and lumens of channels, and that's why there is a definite role of bronchodilators. Salbutamol, pipravate, and adrenaline are three generally commonly used bronchodilators in childhood age. The safe form is a salbutamol. Generally, we prefers in case of COPD, as there is a less extrapyramidal symptoms in the childhood age with the salbutamol, and that's why we consider it as one of the safe drug over the aminophylline and anifylline groups. Then steroidal anti-inflammatory drugs. Yes, definitely. If the inflammation is more and there is obstruction is more, there is a hair hunger and there is a respiratory distress in any form, nasal flaring, cyanosis or anything, definitely we have to choose the steroidal anti-inflammatory drugs like dexamethasone, dexamethasone, and hydrocortisone. Oxygen. It has to be considered in researches that oxygen itself having a capacity of bronchodilation. So stimulation with
Sir, you are not audible. Your PPT is not visible right now. Swapnil sir. So it is due to some technical problem. Swapnil sir is left the session. He will be joined shortly. Please have some patience.
Okay, oxygen. Okay, okay. Hello, sir. In hello. Hello. In आलं ना सर याच्यात मी आलो ना.
Your voice is audible. Where you are?
I'm in meet now, sir. Hello.
Yes, sir. Your screen is visible.
Uh, no
Go on,
PPT
sir.
is visible. Uh,
Oxygen,
PPT.
oxygen.
Okay, okay.
Yeah, right now.
Yes.
Correct.
Okay. So oxygen, the different researches have been found that oxygen itself is a very good stimulator and causes the bronchodilatations in pediatric population. And free flow oxygen at the range of 2 liter per minute is a very good choice in such cases. Antibiotic and antiviral is a choice of that particular pediatrician and physician if he suspect any secondary bacterial infection or if he is supposed to prevent any bacterial infection or further course of the disease considering the vulnerability of that population. Preferably amoxicillin with clavulanic acid in recommended doses and schedule is found to be useful to avoid such incidences and consequences. Antiviral, though it is of very less use, but in intensified cases, epidemic areas, we can definitely use whenever there is you found any epidemics of adenovirus or respiratory syncytial virus, or now we having flu, different varieties of flus and epidemics of flus. Anticholinergics to relax the smooth muscles is definitely used. Leukotrienes modifiers, as we know, the process of inflammation has been triggered by cascades of reaction by the tissue factors, and especially interleukins are more responsible for such cytokines and different reactions. So, leukotriene modifiers like montelukast are of very good use in pediatric population, and researches has been established its safety also. And along with the second generation antihistamines, it found to be very good to control the situation. Expectorants, yes, definitely children are not able to expector the any type of mucus or you can say balgam. So generally expectorants are of definitely use in such a cases. If the clinical findings suggest you of the crepes, definitely we can go for the expectorants. Antihistamines, antihistamines are of use in such a cases. Generally chlorpheniramine maleate, CPM or pheniramine maleate is should be the drug of choice in pediatric population as higher molecules are not well tolerable or you can say can have some side effects in the pediatric population. But yes, definitely the child more than 8 years and around the 12 years, definitely we can go for the cetirizine, levocetirizine generations. After considering all this management and all parts of pediatric COPD, let's go towards the how Ayurveda look into this matter. Yes, Balyavastha and Pratishay. You can say they have hand in hand correlation. Means there is a yes, or I can say there is a no one in this universe that during his childhood age he don't have a common cold. So it is very common. Balyavastha and Pratishay goes hand in hand. Considering the Balyavastha's kapha dosha predominant avastha, which is very physiological also, and because of that pratisha is the very actual responsible cause which gives rise to pratisha gives rise to kasa shwasa, the later on phases respiratory pathologies. Dosha predominance, there is a predominance of kapha and vata dosha. In such cases we can consider it in very proper way. Shrotas involvement is a pranavah, udakvah, annavah and rasavah srotasa. Lines to be remember always. Urastha kurute shwasam amashaya samudbhavam. It means though pratishay, kash, shwas, shata, different varieties are there, definitely maximum pathology has been started from amashaya. And this is a very important clinical line one has to be always remember while treating the patients. That is urastha kurute shwasam amashaya samudbhavam. The quotation is from Ashtanga Hridaya. Chikitsa. Chikitsa we can take into the two perspectives, that is a Vata Pradhana dosha and Kapha Pradhana dosha. As we have already seen, there is a Kapha and Vata dosha predominance. So for Vata Pradhana dosha, Snehana Svedana and Brahman Chikitsa should be applied for pediatric age group, and specifically Hasta Sveda, Nadi Sveda are preferably be used, and Attam Lavana Tailena, which is the Chikitsa Sutra given by Acharya Charak, is very useful to improve the pulmonary compliance of such a child, and that also has to improve the functional residual capacity as well as the functional residual volume also. Brahmana, we should always take into consider that Brahman should be there, as such a diseases continuously causing Kshaya, Dhatu Kshaya in children, and considering this, we should always use Brahman Yoga. Kapha Pradhana Dosha, yes, go for a Vamana. In childhood age, there is a natural Vamana or Chardi Vega is there. So you have to just induce with the Snehopak Dravya like Yashti Madhu, or even in certain cases, people Yashti, Shati, Avalki. This can induces Vega, and woman is found to be very useful. After Vamana, Rukshan and Langana should be followed. Always considering the childhood age, Langan should not be in the form of anashan or very intensified calorie restriction. Rasayana, different lehana mentioned in Kashyap Samhita. Acharya Kashyap has been mentioned different types of leha or lehanas for the such avasthas, atishaya kasa avasthas. The one can Acharya has been mentioned the Vardhaman Pippali Rasayan also for such cases, and it are found to be very useful in day-to-day clinical practice. Chosat Prahari Pippli, that is the Chosat Pippli is commonly known, and that has been found is very in the form of lehana. It has been found very useful. The other Rasayana like Vyagri Harit Chavan Prasha and Vasav Leha, Agastya Harit Kileya, numerous Amrut Prasha, numerous numbers are there that are also found to be useful because they do the Bruhan effect. Then some Rasaushadis, yes, nowadays we have complicated number of cases, everyone is in a hurry and we have to enhance our results, and that's why some Rasaushadis can also be used with the precaution and safety in pediatric population. Now those are those Mrigashanga Bhasma, Godanti Bhasma, Pravala Bhasma, Abhraka Bhasma, Rasa Sindura, Shringarabra Rasa, Lakshmi Vilasa Rasa, Laghu Malini Vasanta Rasa, and Kafaketu Rasa. Yeah, these all are the highly useful, and with the very good drug dependency, dose management, one can use it precautiously in pediatric population and can get definitely excellent result. Now, masses to be taken at home. COPD is less common in younger child, but yes, it can be happen. Specifically occurred after 12 years of age, as we already discussed. 8 to 12 years is that age bar limit from where we have to consider it into differential diagnosis. Mostly as a complication of primary pulmonary pathology, and generally COPD is in children is a complication of primary pulmonary pathology like pneumonia, etc. Management is most of occasion it's a symptomatic. Ayurveda consider it as a Vata Kapha Avastha, and management depends on the dosha predominance as we have already seen in previous slides. Summary, though COPD is not as primary disease in pediatric age group but can be prevented in future as complication of other pulmonary pathology with timely diagnosis and management. Thank you. Thank you very much. Hello, sir. Hello.
Ah, sir, you are audible.
Actually, over, sir.
Yeah, yeah, yeah.
Yes.
I requested to all the faculties, do they have any kind of queries or they want to ask some questions? They are welcome here. Any question? Sir, I want to ask some question to you.
Yes, sir.
I'm audible to you, sir?
Yes, sir. Yes.
Sir,
Yes, sir.
I want to know about what you explain about the Wallery and COPD. WALRI, Wallery.
Actually,
So stop sharing.
okay. Audible, sir? Hello?
Yeah, sir.
Huh.
So what do you explain? We don't get it. Wallery, WALRI.
Yes, sir. These associated lower respiratory infections. So generally, Valri we considered episode Valri as a episodic, and that is in first 3 years of life. So that is a technical term we use from bronchiolitis to bronchial asthma in
Okay.
between. And very first of all, if any child come to us with the breathlessness, wheezing, and coughing, then we consider in initial phase as a bronchiolitis, as a viral infection. Uh, then, if such a episodes occurred repeatedly over a period of 1.5 month, 2 month, you can say 5 to 6 episode in a year annually, then we are not considering it as a bronchiolitis. We consider it as a wheeze-associated lower respiratory tract infection, VALRI. And if there is a more than 3 VALRI attack in an annum, then we have to think about hyperreactive airway disease. And then we have to scrutinize and close monitoring of such a babies. And by the age of 3 to 5 years, such may baby may get lined up into the bronchial asthmas. So this is actually a clinical monitoring protocol that we generally observing in such a babies.
No problem. Very nice. Sir, one of your wording was there that these childhood bachu, they have less prevalence of COPD. Why it is so, sir?
It is because, sir, we are waiting for diagnosis. We can't diagnose immediately below 8 years, as there is a physiological growth of the respiratory path, and we have to give some time till the complete growth of pulmonary and airways has to be taken. After the age of 12 years, such a chances are less to get remodulation or regeneration, and there is a permanent insult remain there. After that, we consider it into COPD phases after 12 years of age. That's why age bar is considered 8 to 12 years.
Okay. Sir, I want to again furthermore ask you
Has-
that, yes, sir, am I audible to you?
yes, yes, sir, definitely.
Okay. Sir, what is your prescription regarding the Ayurvedic consistency of what you explain, antitussive, then bronchodilator,
Yes, sir.
mucolytic and all.
Huh.
So, how we can use all these in Ayurved way? Vasavile, one of the things you explained, but
Yes,
it
sir.
is not a bronchodilator. So, which medicine you recommend in bronchodilator, antitussive, and
Generally,
yes, sir.
yes, yes, please, sir. And anti.
Antipyretic and oxygen related all.
Okay. Generally, sir, if you want to get to little early results, generally, as we just discussed, generally I go for rasaushadis in such a
Okay.
cases like Mrigashringa, Rasusindura, and Shringara Brothers. In
Okay.
some intense cases, when we need early result in the form of bronchodilation and relief in the breathlessness. So by that time, Shringarabra, Mrugashanga, and Avgraka, Rasindur, preferably my choice. And in between the episodic time, to improve the immunity and improve the pulmonary health, Lagumalni Vasanta, Kafaketu Rasa, and Lakshmi Vilas Ras. This is my clinical judgment, sir, actually.
No, it is good.
Uh,
Actually good.
uh, uh. So in that way, generally I prescribe to the patients.
Sir, one thing I make you notice that
Mhm.
why there is a low prevalence in the childhood because
Mhm.
with the time duration and with the allergens in
Hmm.
our life we come across,
Hmm.
there is a chances of what we say cytokinin release
Yes.
uh, and that cytokinin releasing factor syndrome that goes more and more with your age. So
Yes. Yes.
in pediatric, each and every antigen or any kind of protein that make allergens in those childhood that directly doesn't affect to their lungs field as a
Pulmonary. Yes.
capacity. Yeah, yes, sir.
Yes.
That
True.
is the
True. Absolute. Yes, sir.
so
Perfect.
that's why, and the episodic things is that we don't recognize because this is the seasonal related, and that's
Yes.
why
Perfect.
COPD is very less among the children.
Yes. Yes.
Asthma is the one of the culprit which can be
Yes. Yes.
concluded in COPD. Yes, sir. You explain very well what you say.
Yes. Definitely.
So this is all about Dr. Swapnil C. Raskar sir. He explained the childhood COPD in a very interesting and attractive subject in Bachu. Swapnil sir clearly explained COPD with the pathophysiology, with all the pictures and its category either. The differential diagnosis is associated with the bronchitis, bronchoectasis, HRAD, bronchiolitis, pneumonia, and H bar especially. Wheezing with exacerbation, that is breathlessness on the little efforts, triggering factor for hypoxia. Then he explained furthermore the lower respiratory tract related Wallary and COPD. Then the cause of children less prone to COPD and the management in children with bronchodilator, steroidal anti-inflammatory drugs, oxygen corrections, which he explained 2 liters per minute, amoxicillin amikacin, the choice of antibiotic drugs, expectorant and antitussive antihistaminic also. He again wonderful startup in Ayurveda as childhood with Pratishay, Kas, Shwas as a Nidanartakar path in the Vyadi. The Chikitsa regarding the Vata Pradhan dosh and Kapha Pradhan dosh, he explained wonderfully with Ayurveda combinations. Then again he explained Rasayan formulation. It was nicely explained in its category. And for non-recurrence, he explained a wonderful Rasaushadhi with careful choice of a wonderful part. He explained so beautifully. So this is all regarding Dr. Swapnil Raskar sir and his session. We loved it very well. So now we are going to conclude our session. Sir, do you have your permission, please?